Oh, okay. I'm being recorded now. Okay. So there are hyperactive symptoms, there are impulsive symptoms, and there are inattentive symptoms. Inattention can be selective or sustained, and there are different brain areas involved for all of these four types of symptoms. I guess we don't need to go into those details. We got dopamine and norepinephrine mechanism. Yeah, so in this image, you can see who has in ADHD and who doesn't have, also called daydreaming. So again, this girl is not going to present to our clinic because she's fine. She's just like, daydreaming. But actually, she has ADHD. What are the comorbidities? Most common one is oppositional defiant disorder. If you cannot focus, cannot pay attention, and your parents keep on nagging you all the time, eventually you'll become oppositional. Like, I don't want to do it. I don't care. Who are you? And if they ask you to go right, you're gonna go left because just you wanna just annoy them. So this is oppositional defiant disorder. It's a disorder of childhood. Usually, you cannot diagnose anybody with ODD after age 18. I personally know some people that I would still like to diagnose them with ODD, but yes, technically you cannot. So this is the most common one, and the underlying issue is most commonly ADHD. There are other factors as well. Anxiety is pretty common. Affective disorder means the mood problems, depression, bipolar disorder, tic disorder, mania. Learning difficulties are very common. As per this studies, like 92% people have that because lack of focus. So we do have some ADHD related accommodations that we suggest for the school. Medically, you want to diagnose, rule out sleep apnea. Sleep problems are very common reason for focusing issues. And generally, I see adult population, certainly a 25, 30-year-old comes in, says, I have inattention, turns out he's not sleeping well. Something happened with sleep apnea, they want a stimulant medication. So we tell them that no, you want to treat the sleep apnea part first. Substance use disorders, yes, a lot of disorders can mimic cannabis, most common. A lot of people are using, especially in the states, as legal. Time slows down, focus goes out, you cannot pay attention, higher mental functions are affected. Not for everyone, but for a lot of people. So if you're using cannabis and you think you have ADHD suddenly at age 25, that's a no-no. Use of other medications, seizure disorder, vision problems, growth hormones, endocrine issues. So these are all various factors that we want to rule out. What are the potential areas of impairment? So yes, so it keeps on changing as you grow older. Children, most commonly, we look at the academic issues and their relationship, especially with the parents, peers, and also siblings. And then it can lead to low self-esteem. I don't know if I'll have time, but I can go into some case study that I had. A lady who kept on getting admitted to our hospital because she was cutting herself. She was depressed, sad. 3, 4 admissions, and finally I saw her in a partial hospital program, intensive outpatient actually every day. And then I realized that this lady, although she was doing better with depression, everything, cannot focus. And sure enough, it turns out that she has ADHD, and the mom admitted that she didn't like medications, and didn't want to treat the kid. And now she's so low self esteem, has become more like depression, hopelessness, suicidal thoughts. So I put her on a low dose Concerta. And since then, she was never admitted to the hospital after that. So it was ADHD. It turns out ADHD was underlying issue. Along with that, a little antidepressant, and she was good to go for years after that. Never came back to the hospital, and we never missed her also. so, so this is what happens with these kids if they are missed and are not treated. A bigger problem can come down the road, and this is what the parents would like to focus on when they come in and have discussions with me. As they grow older, they are more prone to get injured. The teenager, they start self-medicating. If you don't properly medicate them, and there are a lot of studies out there, if the ADHD kids are not given any stimulants or any other forms of ADHD treatment, then their chances of using other substances is high, especially cannabis, alcohol, and sometimes amphetamines, cocaine, meth. stuff like that. So they get into this, they start smoking because smoking has nicotine, a little bit stimulant action with that. They get into motor vehicle accident because they are not able to focus or pay attention while driving. They eventually get into legal difficulties as they go into adulthood. If you sample a prison population, there is a decent number of, close to like a quarter of them. Sometimes they have substance use and ADHD symptoms. So, and then occupational, obviously, this is the time when they come back to us, and they are mostly adults and they can make their own decision for vocational and occupational health. At that point, they come back to us and say that, look, doc, I think I need help at this point. I was taking Adderall when I was young, and now I'm not taking it for such a long time, and I feel like I cannot have a new job and I cannot focus. So then we restart the treatment. Okay, so how are we doing on the time? Okay, for now. Yeah, so this is a study done by Biederman showing the increased lifetime substance use in untreated adults with ADHD. And then the pharmacotherapy significantly reduces. So it's unmedicated, medicated, and controls. As you can see, the difference. This is the traffic violation and motor vehicle data. So a lot of studies out there. Yeah, this one has another like a summary of what can happen if it's not properly treated. Accidents, drop off, society problems, family, parental divorce, sibling fights, all these other things can happen as a consequence. Biederman did this study in 1998 that inattention keeps on going with the age, and hyperactivity and impulsivity fall. So those symptoms get better, and inattention stays. So let's move on to the treatment, education, behavioral therapy, psychosocial interventions, and and pharmacotherapeutic intervention, which is a heavy duty name for medications. So let's start with education part. The parents, they need to be educated. What it is, why it happens, is it a real disease? As I showed you the slides, the brain scans, are different. Once I did this presentation, and after a little while, I got a request to order a brain scan for my kid. We don't do brain scans for diagnosis. They are not recommended. It's a clinical diagnosis, has to be done on the clinical basis. And yes, a lot of people will meet the criteria. We have to figure out which one to choose for treatment, what type of treatment, but everything is clinical. And we don't need to go for brain scans, but brain scans are done just to confirm that is there a biological part of it, uh, and also PET scans to see if there is like a different area of the brain responding differently. So yes, it is a real disease, and we need to treat it, and we need to understand the causes that can be medical, environmental, genetic. All these causes can be a part of the etiology. It is not due to poor parenting. So yes, so parents have to stop blaming themselves because the kid has ADHD and cannot control themselves, and because they had ADHD or somebody else in the family has it, it's not their fault. So this is a disease just like any other disease. If you develop diabetes, hypertension, it's nobody's fault. This is a disease that you have. Now you have to deal with the treatment, and you don't have to play the blame game and it's because of you or us. Uh, so environmental restructuring. So there are classroom changes that can also help. There are ADHD friendly modifications in family, work, leisure activities. There's a structure, list, delegating, all these things. We'll talk about that in a minute. There are parent support groups. They are all over the place. There are special schools, special colleges that are being, special desks in regular schools, accommodations that are being offered to as a accommodation to facilitate the learning for ADHD kids. And similarly, the parent support groups where the parents can get together and talk, and usually they invite some expert in the field to talk about different aspects of the treatment and possibilities. The goal is to so the behavioral treatment is a form of psychotherapy that can be employed for younger kids. For older kids, it's mostly cognitive behavioral therapy, which is effective. For younger kids, it's the behavioral treatment, and the goal is to reduce inattention and disruptive behavior. So you ensure the structure and predictable routines for them. You don't keep on changing things. Employ cost response token economy systems, like if they get a star or 2 stars or coins, they can buy something, maybe go to a dollar shop and do their shopping there. It's more inexpensive. Uh, so these are the things that give them incentive to do the right thing and not do the wrong thing. Use daily report cards, teach organizational work study skills. Very important nowadays. Everybody has phones. So I tell my patients to open up and organize themselves, put them in the calendar, their appointments, important things. I know some kids who have alarms set up for everything. So they know that they're going to forget. So they put alarms in there, and that helps them a lot. So, yeah, how to organize yourself. Old timer, I've seen, I think probably the oldest one I've seen was not a kid. He was like 71, and this guy came in with his diary, and I asked him, "Do you really have ADHD? Somebody gave you Ritalin? Are you 71?" I don't know, because I also see adults, and he said, "Yeah, sure, doctor." And he opened up his diary, and the diary was full of these stick-on notes and everything. And I'm like, "Okay, that's it. I'm convinced. Please close the. We're done." So at that time it used to be daily planners, the diaries, the calendars, you stick on notes and everything. Now the kids have the phone, and they very nicely and neatly have their stuff in there with the reminders, alarms, snooze buttons, stuff like that. So anyways, organizational techniques are a part of behavioral treatment. So other psychosocial interventions include parent education, naturally occurring consequences to teach social skills. Social skills are very important, because a lot of times these kids, by the time they get to us and treatment is started and optimized, they've missed out on a lot of social cues while growing up. So these are the cues that from 2 years to usually 4, 5, 6 years, we learn, like how to say hello, thank you, goodbye. So they tend to be a little bit odd. The kids don't know, and they are impulsive, so they miss a lot of social cues. So when I was a fellow, I used to do the social skills group with the kids, little kids separately and the adolescents separately, to teach them these skills and kind of model these social behaviors. Reinforce positive behaviors, correct negative behaviors, establish and maintain house rules. So this is a job of the parent, especially the bad cop at home, the disciplining parent. So that is the person that gets the brunt of work to do this, how to maintain the house rules. So we target specific behaviors, playground aggression in the social skills training. There are more effective groups, natural environments like school or camp, and the conflict resolution, obviously, stress management, relaxation techniques. These are all a part of the social skills training. Then we have academic skills, time management, study skills, all these other things. A lot of times there are other academic deficits, like reading disorder, dyslexia is pretty common. So whenever we see them, we recommend that they should be tested in the school for academic and as well as psychological testing, to rule out other causes and other things that we can do to help them and give them accommodations, or different things like extended test times, sitting close, preferential seating, stuff like that. Okay, so now coming to my main job, which is the pill pusher. It's the stimulant medications, medication management. I love to do the other part. When I was a fellow, I used to get more time to do therapies and groups and everything, education, and I used to enjoy that. But now our role has been unfortunately limited to more medication management, and I guess for the right reasons, because people are more aware. There's more patients coming in, and the other things can be done by social workers and nurses, and there are a lot of people who are helping, and they're doing a great job. And so our role has become more like a specialized medication management uh, specialist at this point. So we would try to focus on medications and try to, tailor a plan that would be the best moving forward. And it's also a fluid plan as we go along. I tend to see my kids every 3 months at the most. if they are on good maintenance treatment, because things keep on changing and we have to keep on changing the medications, the doses, manage the side effects. So basically, there are two categories: stimulants and non-stimulants. So methylphenidate and amphetamine, these are two groups in stimulant medications. They've been out there for a long time. Then there is a non-stimulant, which is atomoxetine, which is Strattera, is the brand name. And then we have second line medications. Bupropion is the most common one that I use. There's tricyclic antidepressants and antihypertensive medications. And one would think, why do you want to use the hypertensive medications, clonidine, guanfacine? Do the kids have high blood pressure as well? Answer is no. They are used because of their mechanism of action. They are supposed to drain all the chemicals in the brain. So dopamine, norepinephrine, serotonin, they just drain everything. And that somehow, we don't know the exact mechanism, but it helps with the hyperactivity part, especially of the ADHD. So these are becoming increasingly popular after their discovery that they do help with hyperactivity. They calm people down. They have minimal side effects. So generally, a lot of parents like to start with these if the kid has only hyperactivity, hoping that once the child is not hyperactive, will be able to focus better. They also help sleep with the sleep issues because they just kind of makes you sedated. Especially the clonidine is more sedating than the guanfacine. So these are different choices that are available. Stimulants are the main the drug of choice in ADHD treatment and the gold standard of treatment. We'll talk about that. What they do is the stimulants, they block the uptake of neurotransmitter dopamine and norepinephrine. So they work with these two. And then this Adderall group, the amphetamine group, also activates the release of these chemicals. So it has a double mechanism of action. As I said, there's methylphenidate and amphetamine. Amphetamine has double mechanism, not only blocks, but also promotes. So it's more powerful, basically, than methylphenidate group. So they've been studied as psychotropic medications since 1930. So they've been out there for almost a century now. And side effects are generally mild, short-lived, in response to dose or time adjustments. No consistent reports of behavioral rebound, motor tics, dose-related growth delays have been found. So these were the common side effects that were kind of myths, most likely, in the beginning, that they cause these problems. And then in my practice, also another practice, and in the studies that have been found that these are not the major concerns while treating them. What are the major concerns? These are the concerns that we see most commonly. There is appetite loss, and we would like to monitor the weight as we go along. A lot of kids, they tend to have a slow weight gain or no weight gain. Actually, they lose weight, so we don't want them. Mostly, we want them to gain half to 1 pound every month. Insomnia is pretty common if taken late in the day. Nervousness, yes, it can cause anxiety feelings. And then sometimes there's a mild increase in pulse and blood pressure, irritability, dysphoria, mood changes. So that can happen on high doses. These are high dose effects, these side. They can occur in more than 5% of patients and more in placebo. Which are, and these controversies we talked about already: growth deficits, tics, seizure, abuse. Okay, so in the non-stimulant, the Strattera is a very common one. It came out in around 2003. Non-stimulant medication was approved for treatment in ADHD. Now in America, it's also first-line medication along with the stimulants. But in the rest of the world, it's considered second-line medication. I remember when I was a fellow, it came out as an adjunct to stimulants. So some people cannot go up on the dose for certain reasons. And so we would add atomoxetine or Strattera, and they will do better with the balance. But later on, it was found that even if you stop the stimulants completely, Strattera can do the job without any problems. It's not addictive as compared to the stimulants. Have addiction potential only for the people who don't have ADHD. For kids who have ADHD, I have not seen a single kid being addicted to stimulants. So this one is non-stimulant. A lot of people like to take it if they don't want stimulants, and so it's not a substance of use. So it's easily prescribed by the primary care doctors. The only problem with this one is it's very expensive. Even the generic is expensive, so insurance companies don't pay for it. They want you to try the stimulants first, most of the times. It's well absorbed, has long-lasting therapeutic effects. Efficacy is less, is 0.62 as compared to 0.95, which is the effect size. So it's a little bit less effective than the stimulants. Most of the people who take stimulants, they respond positively. Tamoxifen, about 60 to 70% people responded positively. And you have to get to the higher doses quickly. And sometimes there's a tolerability problem with this. And then obviously the cost is another problem. Another issue is that it takes about 2 weeks to work, while the stimulants, they work right away within 3 days. Okay, so it should be considered the first line treatment, especially in the children who already have a history of substance abuse. So if there are kids who are already used to abusing drugs or giving it to their friends for fun, the stimulants, you want to give them the Statera. And then there are significant anxiety symptoms associated with that. Sorry, it can actually help with anxiety because it originally came out as an anti-anxiety, antidepressant medication. Atomoxetine is like a sister of fluoxetine, sertraline, that group. So, but it did not get an approval for those indications. Rather, they saw that significant increase in improvement in focusing. So they did another study that got this medication an approval for ADHD. And then we have dosing here. Okay, so that's about it. Modafinil, it was studied. It's also a stimulant, and it's approved already for narcolepsy and shift work sleep disorder. And they were trying to get approved for ADHD, but in the trial, one patient had Steven-Johnson syndrome, which is like peeling off of the whole skin. So then that happened. They aborted the trial and never came back. So unfortunately, we missed out on this trial. But rarely, if somebody has a comorbid condition with something else, we can use the modafinil as a stimulant. It helps with the focus as well. Tricyclic antidepressants. I haven't tried that most of the times. It helps with the insomnia. It is taken at nighttime, and there are some new formulations that have come out in ADHD that are actually given at nighttime, and they start working the next day. Similarly, Strattera or atomoxetine it can cause sedation in quite a few patients. So if that happens, then it can be given after dinner, and then it takes about 2 weeks to work. Okay, so you got that. Wellbutrin is also another one of my favorites, especially for kids or adults who have ADHD and also diagnosed with major depressive disorder. This can be a very useful medication. It's also not a controlled substance and does the same thing theoretically: dopamine and norepinephrine reuptake inhibitor. So, but it's not that strong as stimulants. So we have to go up on the doses to get the similar effect. For ADHD, it has different formulation: long acting, short acting. The short acting is approved for ADHD in one of the trials. It's underutilized, and a lot of times people don't use it, don't want to use it. If you have seizure disorder history, it's contraindicated. But I've seen this in people who don't want to try the stimulants or the controlled substances. It does give a lot of benefit for ADHD symptoms. It gives you energy, weight loss, which a lot of teenage girls like as well. So it can be used at different points. It's approved for kids 16 and above, but sometimes I've given it to 15, 14-year-old with the consent of parents because there's no other choice left. The blood pressure medications, alpha 2 agonists, antihypertensive, clonidine, guanfacine, again, very useful, very effective for kids who have both autism and ADHD. They downregulate the noradrenergic system and effective for ADHD symptoms and tics. So if you have comorbid tic disorder, then you can try this. Sedation, headaches, dizziness can occur as a side effect. Not useful to control distractibility itself. Yeah, so it's better for hyperactivity rather than the inattention and distractibility. And also it helps with the sleep. Okay, so this is the study that got the approval for stimulants. It's called MTA study, multimodal treatment study of children. Uh, so for ADHD, so MTA, it was a 14-month trial. This was a big trial funded by the government in 1999. They did a follow-up in 2003, and this is the landmark study that made the stimulants the gold standard treatment. Anybody who's interested in seeing why we're promoting these stimulants is encouraged to look at this study in detail if they are interested in that. So basically, there are four wings: medication management only, behavioral management only, combined treatment, and community-based treatment means whatever the primary care doctors were doing in their clinics. And then they found out that all treatment arms were effective. The medication management alone or in combination with behavioral management was almost equally effective. So that means that if you don't have access to therapists, do not withhold the medications. Only medication by itself can give you enough support. And this is the chart here. As you can see, 56% response, 60% with therapy, 4% decrease. Only with therapy, only community-based. So as you can see, the medications were the winner. And this study has been replicated multiple times. Okay, so a little bit, a few words about adult ADHD. It starts in adulthood. The diagnosis is often delayed. So most common form of adulthood ADHD that I see is usually the same story. When I was young, I had problems. My teacher sent me for evaluation. Doctor wanted medication, but my parents said no. And then, the kid kept on failing. Eventually, dropped out, did drugs, marijuana, this and that. Eventually, settled down somewhere and now working and came back to get treatment. And now he's adult and make his own decision or her own decision, and now they want treatment, and now nobody will give it to them because now they have a drug history. So this becomes a problem. So this is the most common story that I get for adult ADHD. One way we deal with it is to send them for neuropsych testing. Very expensive, about $2,000. Nobody wants to pay that. Whenever you hear this neuropsych testing, it generally means the doctor doesn't want to give you the strong medications. So the compromise is to go with the non-stimulant, non-controlled medications like Strattera, Wellbutrin. If you have more ADHD with anxiety, go with Strattera. More ADHD with depression, you go with Wellbutrin. Even without depression, only ADHD, you can go with those, or tricyclics, or you can go with Effexor is another option. So that usually works, and that's kind of a litmus test because there are certain people who come in and they want only stimulants. So we know that this is something else. They don't want treatment. They want to get high or whatever. So a lot of doctors think like that. So what you want to do is just be objective, go there and let the doctor decide what kind of medications they would like, and then you can pick and choose out of those medications that are being offered at that point. Somebody uh, I went to a presentation who did a very nice thing. He said, if you want to give somebody and you know that you want to confirm, there's one question that you can ask. Instead of getting the neuropsych testing done, you can just ask them, can I call your mom? That's the question. Can I call your mom or dad, whoever? And if they say, sure, call them. And they call them, and the mom says, oh, yeah, yeah, this kid was all over the place. He was, there's so many bad problems and this and that. So why didn't you treat them? Oh, we didn't like the medicine. That's like a, confirmed diagnosis right there. That the patient has ADHD that was never treated, and now he's ready for the treatment. So you offer, and then we go with, based upon other factors, we suggest a treatment plan. So majority of adults with ADHD, they struggle with anxiety, depressive disorder, substance abuse, as well as other psychiatric problems. So if that's the case, then you want to treat the comorbidity. If it's for young kids, the recommendation is to treat the ADHD first. This is another common question I get. If kid has ADHD and anxiety and learning disability and blah, 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 what do? What you do is you treat ADHD first. That's a recommendation. If it's an adult and you have comorbidity, then you have a choice. But most commonly, it's the other issues that you want to treat. If they're going through domestic violence, if they're going through major depressive disorder in a hospital and they're suicidal, you want to treat those things first. And then see if there is a leftover ADHD component that needs to be addressed. So that's how we generally treat, and it's a different approach depending upon the age because the problems are different. The behavior of adults with ADHD directly affects others around them, parenting skills, impulsivity, and overall impatience. The treatment can be helpful in all of these domains of impairment. So we went through that. What are the domains of impairment and what can be done? Generally, when you treat the ADHD, it just improves all overall functioning and academics. Okay, so yeah, so these are the symptoms. Many times the patients are overwhelmed. This time they are overwhelmed because this is they're not sure about the diagnosis. Their function is being affected. Their bosses are threatening them that if they don't get the work done, they will be fired. So it's a stressful situation that you want to assess and treat on time. The diagnosis of ADHD always should be considered when evaluating psychologically distressed, non-psychotic, non-demented individual. So yeah, so this is a rule out. Whenever I do diagnostic evaluation for anything, there's always a question: was there ADHD ever being diagnosed or treated? So we go with that. Adults with ADHD are no more compliant with their medication regimen than other patients with chronic disorders. They only half the medication prescribed to them. So it's pretty standard, about 50 to 60% compliance and adherence rate. And that can lead to a lot of times patients come to me and they say, medicine is not working. Okay, when did we meet? 2 months ago. I gave you 1 month supply. What happened? Oh, yeah, I swear I've been taking it till yesterday. So unless the pills are multiplying in the bottle by themselves, you cannot do that. So I tell them, and especially for things like Strattera, Wellbutrin, you need to build up on the levels and titrate the doses. The other thing with the stimulants is some people take it as needed. If they have tests, they will take it. If they have exams, they will take it. That's also not recommended. Drug holidays are kind of controversial. The pediatricians usually tell them don't take it on weekend or summertime. American Academy of Child and Adolescent Psychiatry recommends taking it daily, whether it's a holiday or weekend or summer or winter break, whatever. ADHD does not take any holidays. It's present each and every day. There should not be any day when you will stop treatment. Because if you stop treatment and start treatment, this is like a mixed message to the brain. One day you have more dopamine, the next day you have less dopamine, then you have no dopamine, then you have more. So the brain gets messed up. In order to have a successful treatment, and I think probably I took that slide out of this, and that's also another question that comes to me, whether the patient will be able to stop the medication at some point. Yes, the data indicates 40%, 40% of kids are able to come off of the medications if they are properly treated by the time they get to age 18. So that might be because some of them don't go to college or some of them don't do any work that requires sustained attention. But yes, that's the data. If it's properly treated, there's a good chance. If it's mild to moderate disease, by the time you get to 18, your brain will heal and start producing its own dopamine and norepinephrine, and you won't need medication help, especially if you're not doing any attention sustaining work. So that can happen. So it's very important to be compliant with the medication, take it every day in order to achieve the best results. We don't want to put people on medication for the rest of their life. We want to treat them and to enable their own brain so that at some point they'll take over. And then we move on to the next patient, I guess. That's how it works. So yes, so long acting versus short acting. That's another debate that goes out there. Between us and the pediatricians. The old-fashioned way to start medication, my teachers used to tell is like they would just start with short acting and give it 2-3 times a day, and then they'll adjust the dosing and figure out where they need more, where they need less. Generally, in the beginning of the day, end of the day, they need more. Middle of the day, need less. And then now we have formulations that actually have, uh, you know, adopted the most common prescribing patterns. So you can have a long acting that is more in the middle of the day, or you can have double peaks in the blood so that you can spare the lunchtime and you can eat, because that's most common side effect, suppression of appetite. So all these things happen. And so based upon that, nowadays the recommendation is to start with the long acting, something like Concerta or Adderall XR or Vyvanse. These are long acting medications. They are A lot of new medications have come out, and they are all long-acting, single dosing, one dose per day. So you don't have to worry about the timing and compliance issues. As you can see, the compliance adherence is less than 50%. These are most common, a little outdated slide. Now a lot of other stuff has come out, but these were like the basic long-acting medications that were available: Adderall XR, Vyvanse, Concerta, Focalin, and Strattera. It says recent development, but it's an old slide. I apologize for that. So we have long-acting clonidine now. It's called Capvay. We have long-acting guanfacine now, which is called Intuniv. Then we have a lot of other medications that have come out. Different mechanisms, different release styles, different times of administration. They make it more and more convenient for you. We do have a patch as well that kids who don't want to take it. We have liquids, we have chewables, every form of different medications that are available to assist if needed. So gene studies continue to identify potential markers that may be associated with that. There's norepinephrine reuptake inhibitor that has come out in the market already. Brain imaging studies continue to develop at rapid pace. Direct clinical relevance. Okay, so take home. Hopefully, yeah, we are in the last minute. So ADHD is a clinical diagnosis, highly comorbid. You want to see a psychiatrist, child psychiatrist, to rule out other comorbidities and get to the bottom of the diagnosis and comorbidities. The history is the only and the one and only source. No need to do the scans. And it is not only a child disorder, continues in adults. Okay, so this was actually important part, which is in there. I'll let you read it yourself. COVID-19 and return to the school. That was actually the main topic. Continue giving your child your medication. So you don't want to stop them. Help your child maintain a regular daily routine, which I know in summer is difficult. Act before your child becomes bored by joining and educating them in activities that they enjoy. Foster positive behavior. Promote a sense of physical and emotional safety by creating and maintaining a healthy relationship with your child. Try to intervene before challenges arise. So yes, get them an evaluation, look at the recommendations. There are a lot of options out there for people, especially, and I forgot, probably have to update this. Recently, within a year, some studies have come out with omega-3. Omega-3 has been approved for ADHD. One component, I don't remember, was it DHA or the other one? One is approved for mood problems. The other one is approved for ADHD. So a lot of parents who want to do something natural over the counter and don't want to, and they're mild to moderate symptoms, we let them go for behavioral therapy and try the omega-3 and see if that would help. So far, I haven't had anybody come back to me and say that their kid was cured with omega-3. None of them. All of them who have come back, they're looking for some kind of a medication. Help your child process their worries and anxiety by listening to their concerns. That's very important. Limited media exposure. Very difficult, easily said than done. Nowadays, everybody's on the phone, and the phone is a necessity. They have to be. You can limit the times. American Academy came out with a recommendation of certain timings. It was like 6 hours. Then it became like 8 hours. But now it's like they should not have any media around the eating time, and during eating should not have any media as soon as they wake up or before the bedtime. Bedtime should be set, and an hour before that, especially when they're going to school, all the media, electronics, screens should be shut down. And you can have the nice, relaxing bedtime routine, maybe a old timer books and stuff like that, which I guess nobody uses anymore. So you set up rules and you follow them, and you'll see that that also helps with the focus and attention for your kid. Staying connected with families and friends on a daily basis. This is during the middle of COVID that we did this presentation. And reach out. Definitely, if your child is struggling and things are not getting better with the usual interventions, you want to get an evaluation done to see what other stuff is going on. A lot of times, especially teenagers, they don't feel comfortable talking to parents about their issues, so they want to talk to a professional like myself or anybody else in the therapy world. And take care of yourself. I mean, while you're focusing on your child, you might be dealing with some of these issues related to the COVID and what has been going on around us. And if you need help, definitely reach out. Get enough sleep, exercise, um, incorporate stress relieving activities, meditations, guided imagery, breathing exercises. Everything is on YouTube, so you can just go on YouTube and try to see what works for you and your child. And yeah, if you have any questions, we'll be happy to answer. Thank you.
Okay, thank you so much. If we could go back to slide 68, where it presents our contact info, please.
Oh, that I don't have. I think there was
You know, okay, I'll share that. And Daniel will cover that for us, no problem. Oops. All right. Can you see now, Daniel?
Yes, I can see. Yes.
All right, Daniel, can you see this slide? All right, I'll go ahead and cover that. Thank you so much, Dr. Rashid, for your thorough presentation. It was very informative, and we were able to get a lot out of that, a lot of information, both for the children, ways that we can help them, redirect some of the behaviors and medication concerns parents may have, on into those adults that find themselves dealing with these symptoms. So we thank you for that. We wanted to bring your attention to our contact information for contacts and referrals and resources for Beacon. You can contact them at 800-945-4644. And for Parkland members, we have our Medicaid STAR program, which is 888-672-2277. And for our CHIP membership, it's 888-814-2352. And again, we wanted to thank our speaker, Dr. Rashid, for being so thorough and giving your time this evening. Are there any questions? Floor opens up for questions now.
I have a question. Hello, all.
Hello.
Hi. My child is recently diagnosed with ADHD. He is 4 years old, and his doctor recommended him to take Ritalin. He's been taking from 2 months every morning, 5 mg. But after a month, he was again reevaluated, and due to his impulsive behavior, the doctor suggested him to take more 5 mg. But we as a parent, because we just started the behavioral therapy and is also speech delay and also occupational therapy delay, we did not went with the second dose. So I just wanted to get a note like, is it for now? Yes, he's very young, so we should go for the second dose or just go with the first dose and the therapies. Thank you.
Thank you. Yeah, it's a good question. I mean, I don't know the exact particulars. What I do is when I see clients, I usually do like a scale, and that is how we evaluate. It has all those 6 out of 9 symptoms. I like the ADHD rating scale, fourth version. It's online. I guess you have to buy a book in order to administer it. So I get it in the beginning of the treatment, and every year in the school year, in the second month after the start, and the last month before the school ends. There's one done from the teachers, one done from the parents. And based upon that, what kind of symptoms, and it has symptoms, and also how bad are the symptoms, and what
Yes,
time are the symptoms
yeah,
bad?
he's been diagnosed with a moderate ADHD, and he is very impulsive, not at all sitting at a place.
Yes.
And
So
but
is that throughout the
attention
day, or is it in the morning or afternoon only, evening?
is no, it's throughout the day, and it's been like since he was a toddler.
Right.
He does not sit at one place. So and then we were just concerned about it. So we had, because our PCP recommended for the go to with the child specialist. So
Yes. So,
he was diagnosed with moderate ADHD, but like we noticed, like after the medicine is given, he's okay for 4 hours. And
right.
then after that, it's just draining, and then he's very hyper. And so for that, when they recommended the second dose,
Yes.
but he's too young, and we do not want to go. So what is your suggestion on that? So we should go for the second dose or
Yes.
not, because he's going to start the school too, and I think so. Is his first year, like we have to tell the school that, because he's just been recently diagnosed, and he was just after the school.
Yes. So as I mentioned, they are short-acting and long-acting formulation. When he started you on Ritalin 5 milligrams, should have mentioned, I don't start people on short-acting like that. If I have to, I will split the dose. I'll do 2.5 in the morning and 2.5 after 5 hours. That's a standard starting dose for young kids, especially, because that covers the whole day. Nowadays, we have better long-acting medications. I would have probably preferred like something like Concerta or maybe Vyvanse 20 milligrams. That covers you for 6 to 8 hours, sometimes 10 hours, depending upon your metabolism. So that is a single dose in the morning. It covers the whole day, and you don't have to worry about it. If you just do Ritalin 5 in the morning, that's good for 4 or 5 hours. And then there will be breakthrough symptoms in the afternoon because it's not covered. So yeah, if you're concerned about that, you can do split the same pill and give it 2.5 in the morning and 2.5 in the afternoon, and let the doctor adjust. Or you can request a long-acting medication, something like Concerta or Adderall XR or Vyvanse, and that would be a single medication. I like Vyvanse also because if it's too much, you can open up the capsule and sprinkle it on something like applesauce or even in the water, juice. Give it to the kids, and they do well. But 5 milligram, that's basically you're looking at 4 to 5 hours coverage of the symptoms, and that's probably not a good treatment.
So for 4-year-old, so it's okay, like we can give him medicine like the second dose,
Yeah, I
okay,
think
because
that's
we
part
think
of the
like he's too
reason.
young.
Yeah, I think the doctor is trying to stick with the FDA recommendation, which is only for the regular short-acting Ritalin or short-acting Adderall. But they can discuss with you that if you really want to give one a day, they can go with the longer acting, and that might be a better coverage. As he grows up, you'll have much more options after age 6.
Okay, and does the behavioral therapy, does that also help? Because
Oh,
we just
definitely,
started
yes.
a month.
Yeah, 4-year-old is quite young. So if he's
Yeah.
diagnosed, you hope that the behavioral therapy, the star charts, token economy, positive reinforcement, rewards that can be material or can be emotional, like hugs, kisses. These things do help. But in the studies, they've shown to be not as effective as medications. As you can see, the MTA study is 56% versus 60% with the addition of therapy. It's not a huge difference. But yes, overall, those are the skills you want them to learn, so that they don't miss out on those skills. So definitely, therapy and medication combined is the best treatment. You have to tweak the medication and adjust. The short-acting medication should be given at least twice a day, if not 3 times a day. That's how I do it.
Yeah, thank you. And also it was like we were stopping on the weekends, but as you said that like we should not stop on the weekends because
Yes.
yeah,
Yeah,
his brain gets, yeah.
that's a old beef between us and the pediatricians. We keep on fighting.
Yeah. Yeah.
The
So,
other
and this is the
issue is
first.
EKG.
Mhm.
The American Academy recommends getting EKG to make sure there's no heart. They've been reported 8 to 10 deaths with hidden cardiac disease problems. So they don't get it because it's not recommended by American Association of Pediatrics, but we do recommend it to get it, just especially if there's a family history of cardiac problems or heart attacks or stuff like that in the family. We recommend getting EKG before starting the stimulants because it can affect the heart rhythm sometimes.
Thank you, doctor.
You're welcome.
Great questions. Thank you so much. Are there any other questions? All right. Well, if there aren't any other questions, we'll go ahead and thank everyone for joining us this afternoon and spending time with us learning about, again, a very important topic, learning how to manage ADHD amongst our children and our teens. Thank you again, Dr. Rashid, for your time with us this afternoon. And thank you all for coming. You all have a good
Thank you. Appreciate that. Bye-bye.